Tes dulu. Tes dulu. Tes. Tes dulu. Tes. Tes. Tes dulu. Tes dulu. Tes. Tes. Tes dulu. Tes. Tes. Tes dulu. Ada. Nanti dekat masih kiri sebab aku tak dengar. Punya ni ke? Nah, kalau audio dengar lah. Dekat YouTube tapi dia terdengar. Itu kena dekat speaker yang itu mic. Oh yeah.
Assalamualaikum warahmatullahi wabarakatuh and very good morning to our honorable guests yang berbahagia Datuk Dr. Abdul Haris bin Muhammad, Director of HRPZ2, Dr. Putri Nurbaya binti Muhammad Ismail, Deputy Hospital Director 1, Dr. Tengku Anas Fatih bin Tengku Ahmad, Deputy Hospital Director 2, Dr. Nurhana binti Muhammad Fazil, Deputy Hospital Director 3, and Puan Norma binti Yaakob, Deputy Director of Management, Head of Departments, Specialists, Medical Officers, Nurses, and the rest of HRPZ2 staff. First and foremost, I would like to thank everyone for allocating your time attending our CME session. I am Ayunia Ziati binti Azmi from Orthopedic Department, will be your MC today. Before we start our CME, here are some important announcements to highlight. For attendance, kindly scan the QR code on the screen, which will be displayed before and after the CME session, or use the attendance link provided in the live chat of our YouTube channel. For those who join the CME via online, any questions are welcome through the chat box in the YouTube channel. So without further ado, I would like to invite Dr. Muhammad Firdaus bin Zulkifli from Jabatan Rekod Perubatan to present today's CME with the topic of the do's and don'ts in morbidity documentation. Please welcome.
Thank you, Dr. Yuni. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Continuing our weekly CME session, it is done for a medical record department. My name is Firdaus, and I would like to present about the diagnosis documentation for morbidity cases. So, for HRPZ as a tertiary center, we deal with a huge number of a number of patients discharged per year. So for all these cases, the discharge summary, all the diagnoses, conditions, and procedures are documented in the discharge form per PD 301. And these forms will go to medical record department. Each will be assigned codes according to ICD-10 for diagnosis and condition, and ICD-9 CM for procedures. And all these codes will then be keyed into a web-based case-mate system. And this data can and will be used for a number of purposes. And one of those purposes is for hospital financing and budget allocation. That is why it is very important and crucial that we document as accurate and as complete as possible in the discharge form. if you don't do it properly, it can have a negative impact on our hospital. So that is why this topic is chosen today for this very reason. This is my presentation outline for today. We will look at some definition of key terms used in the PD 301, what details to document in the discharge form, the do's and don'ts in documenting diagnosis for morbidity cases, some common errors that can occur, and last but not least, take-home messages from today's CME. And along the way, we will look at some examples of good and bad documentation in morbidity cases. So for morbidity cases in PD 301, we can skip section 2 and 3 because these sections are for mortality cases. So first, we look at the first section, the main diagnosis. It can be defined as the condition diagnosed at the end of episode of healthcare, primarily responsible for the patient's need for treatment or investigation. If there is more than one such condition, the one held most responsible for the greatest use of resources should be selected. In cases where there is no diagnosis was made, the main symptoms, abnormal findings, or problems should be selected as the main condition. For example, diabetes mellitus, we specify the type of DM and its complication. For example, insulin-dependent diabetes mellitus with retinopathy. So in this case, acute pancreatitis is the main diagnosis and was correctly documented in section 1. And next, we look at comorbidity diagnosis, section 4. It can be defined as the disease or injury which initiated the train of morbid events. For example, in a case of acute exacerbation of bronchial asthma secondary to viral pneumonia, in this case, acute exacerbation of bronchial asthma will be the main diagnosis, and viral pneumonia is the comorbidity diagnosis. In another example, in a case of febrile convulsion secondary to acute tonsillopharyngitis, so in this case, the main diagnosis is febrile convulsion, and the comorbidity diagnosis is acute tonsillopharyngitis. And in this case, perianal abscess is the main diagnosis, and the comorbidity diagnosis is insulin-dependent diabetes mellitus. And both conditions were correctly documented in appropriate section. Next, we look at section 5, other diagnosis. It can be defined as a disease that accompanies the main diagnosis and requires treatment and additional care, in addition to the treatment provided for the condition for which the patient was admitted. For example, a patient was admitted for acute exacerbation of bronchial asthma, but at the same time, the patient has underlying hypertension and diabetes mellitus, and the patient still receives care and treatment for both conditions during the admission. Therefore, hypertension and diabetes mellitus will be documented in other diagnoses. In this case, the patient was admitted for perianal abscess, and the patient has underlying condition of ischemic heart disease and essential hypertension, and both conditions were correctly documented in section 5, other diagnoses. Now, remember, we have to write a complete diagnosis. For example, diabetes mellitus, we have to specify type of diabetes. Is it type 1 or type 2? And also, we need to specify its complication, because each will have a different code according to ICD-10. For example, type 1 diabetes mellitus with ketoacidosis, so it will be coded as E10.1. Another example, type 2 diabetes mellitus with peripheral circulatory complication, so it will be coded as E11.5. The same for hypertension. We have many different codes for hypertension. For example, essential hypertension will be coded as I10 according to ICD-10. If hypertensive heart disease is I11 and hypertensive kidney disease is I12. Therefore, it is important that we document as specific as possible in the discharge form. The next one, we look at complication diagnosis, section 6. It can be defined as a disease or condition that appears during the episode of care due to a pre-existing condition or arising as a result of the care received by the patient during the admission. For example, in a patient who has been admitted for infected soft tissue hematoma and was started on IV cloxacillin. However, during the admission, after a few days, the patient developed thrombophlebitis. So in this case, thrombophlebitis will be the complication diagnosis and should be documented in section 6. In this case, the patient was admitted for perforated appendicitis, underwent laparotomy and appendicectomy. However, in the ward, patient developed wound breakdown and ileus post-operatively. So the complication diagnosis in this case are disruption of operation wound and ileus. And in this case, both conditions were correctly documented in section 6. The next one for section 7, the external causes of injury and poisoning. It is can be defined as the circumstances of the accident or violence which produced the injury. So we document any external causes of injury or accidents or poisoning here in this section 7. We look at one example. In this case, the patient was admitted for open comminuted fracture of mid-shaft of right tibia. And the external cause of injury is motor vehicle accident. So it was documented in section 7. However, in this case, the external cause is not quite complete. We look at another example. This one is a good example of external cause of injury. A driver of motorcycle injured in collision with car, pickup truck or van in a non-traffic accident while engaged in leisure activity. Unfortunately, it was a wrong placement. It was documented in the wrong section when it should be documented in section 7. Remember that external causes of injury cannot be the main diagnosis. So it should be documented in a relevant section, in this case, section 7. So we stop for a while for the Okay, continue. There is also diagnosis for elective admission cases that we can document in the discharge form. For diagnosis, we can document electively admitted for, and then we specify the investigation or procedure or treatment, and we also must specify the underlying condition as secondary diagnosis. For example, a patient was electively admitted for colonoscopy in a case of a patient with history of malignant stool. So the main diagnosis is elective admission for colonoscopy, and secondary diagnosis will be malignant stool. Another example, elective admission for continuation of antibiotics, elective admission for physiotherapy, or elective admission for stroke rehabilitation. Each one will have a different codes according to ICD-10. In this case, the patient was electively admitted for laparoscopic cholecystectomy because the patient has underlying cholelithiasis. So the main diagnosis, elective admission for laparoscopic cholecystectomy, and secondary diagnosis or comorbidity diagnosis, cholelithiasis. For procedures and operation cancellation or postponement due to any reason, we can also document in the discharge form. Will be coded using Z codes. These are some possible diagnosis description that we can use for documenting diagnosis in discharge form. For example, procedure or surgery not carried out because of contraindication, for example, URTI. And another example, procedure or surgery not carried out because of other reason, and we specify the reason. For example, no insufficient OT time, for example. In this case, a patient was electively admitted for colonoscopy but cancelled due to poor bowel preparation. So this will be the main diagnosis, and comorbidity diagnosis or secondary diagnosis is the malignant stool. For cancer cases, there are some special instruction to document in the discharge form. In situation 1, if the cancer is still present, the main diagnosis will be the cancer itself, and the secondary diagnosis will be any treated complication, secondary or metastatic cancer, or any elective investigation, procedure, or treatment. In situation 2, if the cancer has been removed, the main diagnosis will be any subsequent elective investigation or procedure or treatment, and the secondary diagnosis will be the cancer post-procedure. In situation 3, if the cancer has been removed, but patient is still undergoing elective admission for secondary or metastatic cancer, the main diagnosis will be the secondary or metastatic cancer. The secondary diagnosis will be any elective investigation or procedure or treatment, plus history of primary cancer. For example, in a patient with breast carcinoma post mastectomy admitted for chemotherapy. So the main diagnosis will be elective admission for chemotherapy, and secondary diagnosis will be breast carcinoma post mastectomy. However, if the cancer is still present, we must state the cancer as the main diagnosis according to these rules. In this case, the patient was electively admitted for chemo port insertion. So that will be the main diagnosis, and the secondary diagnosis is malignant neoplasm of lower outer quadrant of breast. In injury cases, when documenting diagnosis in the discharge form, the main diagnosis should include, we specify the type of injury. Is it fracture or dislocation or wound? We specify site of injury. And if it is fracture, we need to mention, is it open or closed fracture? And if it is internal injury, for example, splenic or liver injury, we need to specify, is it blunt or penetrating injury? The external cause of injury should include, first is patient's mode of transport, for example, pedestrian, motorcycle, or car. Second is patient's role, rider, driver, or passenger. The third is mechanism of injury, for example, collision with car or skidded. The next one is place of occurrence, for example, school, home, or at work. And last one is activity, for example, sports or while working. So let's look at some examples. The first example, the main diagnosis is open fracture mid-shaft of right humerus, And the external cause for this case is motorcycle rider in collision with car on highway on the way to work. So in this example, the main diagnosis was correctly documented because it specified the type of injury, the fracture, the site of injury, mixture of right humerus, and because it is fracture, we specify it is open fracture. And for the external cause also is a complete sentence. We have the mode of transport, motorcycle, the patient's role, rider, the mechanism of injury in collision with car, the place of occurrence on highway, and the activity on the way to work. That is how to document the external cause of injury. And the rest we document accordingly. For example, in this case, the main procedure is open reduction and internal fixation of right humerus and also X-ray of right upper limb. Next example is a burn injury. The main diagnosis is 20% second-degree burn of chest wall and bilateral upper limb. And external cause of injury for this case is accidental gas tank explosion at home during cooking. So again, in this case, the main diagnosis was correctly documented. For burn injury, we have to specify the degree of burn. In this case, second degree. The site of injury, in this case, chest wall and bilateral upper limb. And also we need to specify the percentage of body surface area, in this case, 20%. And for external cause, other than transport or traffic accident, we have less component that we need to specify in the external cause. For example, in case of burn injury or falls, we need to mention the mechanism of injury. For example, contact with hot water, fall from bed or stairs or trees. And second is we need to specify the place of occurrence. And last, we need to specify the activity when the incident happened. So in this case, the mechanism of injury, accidental gas tank explosion, the place of occurrence at home, and the activity is during cooking. And again, we document the rest accordingly. In this case, the procedure was wound debridement under general anesthesia. In this case, the patient was admitted for closed intertrochanteric fracture of left femur, and the external cause of injury is LH4. In this example, again, similar to previous example that I showed, we should not write the external cause of injury as the main diagnosis. It is a wrong placement. It should be documented in section 7. Sorry? LHMVA. This one is a bad documentation because, as I mentioned, we should not document external cause of injury as the main diagnosis. It should be documented in section 7, the external cause of injury. That one is other diagnosis to rule out pulmonary tuberculosis. We document the rest in other diagnosis. So in this case, we should select the one diagnosis that is more severe. For example, in this case, maybe we should select splenic injury grade 3 as the main diagnosis, for example. And the rest of injury will be documented in other diagnosis. Only one diagnosis should be documented as a main diagnosis. And the rest of injury will be documented in other diagnosis. The most severe and demanded more resources compared to the rest. Splenic injury grade 3, for example. And the rest of injury documented in other diagnoses. Yes, the other diagnosis. And LHMVA should be documented in external cause of injury, section 7. In some cases with multiple conditions, where an episode of healthcare concerns several related conditions, the one that is clearly more severe and demanding more resources should be recorded as main condition. However, in cases when none of condition predominates, then a term such as multiple injuries may be recorded alone, and then we record each single injury in other diagnoses. For example, a close fracture involving multiple regions of both lower limbs, we document as a main diagnosis, and then we record each single injury in other diagnoses. For example, close fracture of neck of right femur and close fracture of midshaft of left tibia. In cases with uncertain diagnosis or symptoms, if no definite diagnosis has been established or can be made by the end of an episode of healthcare, then the information that permits the greatest degree of specificity and knowledge about the condition that necessitate care or investigation should be recorded. This should be done by stating symptoms, abnormal findings, or problems, rather than mentioning a diagnosis of possible, suspected, or to rule out. Let's look at one example. Let's look at some examples. A patient came with fitting. So instead of writing a diagnosis of to rule out epilepsy, because the diagnosis cannot be established yet, so instead we can write, we just document fitting or seizure as the main diagnosis, and it will be coded as R56.8 in this case, as the main diagnosis. We should avoid the words of suspected or to rule out or possible. In another example, a patient came with a complaint of epigastric pain. So instead of writing suspected peptic ulcer, instead we can document as epigastric pain, and we record it as R10.1 in this case, as a diagnosis. Yes, because the diagnosis has not been established yet. So we can document the symptom as the diagnosis, as the main diagnosis. Yes, we can document that, but the word alleged MVA will be coded in section 7 instead of main diagnosis. Yes. But we have come across many diagnoses when the discharging doctor document alleged MVA with, and the person specify the injury. That is not totally wrong, as long as there is a diagnosis other than alleged MVA in the main diagnosis. So in this example, the discharging doctor documented unlikely IHD as the main diagnosis. So when we do audit for this case, we check the history. The patient was actually admitted for elective admission for angiogram. So instead of writing unlikely IHD, we can document elective admission for angiogram. And we document other diagnoses in other condition, essential hypertension, and normal angiogram findings. For sequelae, the sequelae includes conditions specified as such or late effects for those present 1 year or more after the onset of causal condition. For example, a 50-year-old male diagnosed with thromboembolic stroke with right hemiparesis, and the event occurs in 2010. So instead of writing thromboembolic stroke with right hemiparesis, because it is not a recent event, we can instead document as sequelae of thromboembolic stroke, and there is a specific code for this condition in ICD-10. Some do and don'ts in documenting diagnosis. Do proper documentation of main diagnosis. Legible handwriting. I think for our hospital HRPZ, this should not be a problem, because the discharge form is done through SPP, it's computerized. But for some district hospital, when the discharge form is still being done manually, please make sure that it is a legible handwriting. to document all other conditions under relevant headings of other diagnosis, and to also document procedures in the procedure column. Do not use any abbreviation and do not write procedures as the main diagnosis. Now, regarding using abbreviation, one abbreviation can have multiple meanings, and this can lead to errors in assigning codes for the condition. Here are some examples of abbreviation that have more than one meaning. For example, PE in obstetric cases. So is it preeclampsia or is it pulmonary embolism? The next one, next example is PID. So it can mean prolapse intervertebral disc. It can also mean pelvic inflammatory disease, and it can also mean primary immunodeficiency. So we don't know which one is which. The next example, PHTN. So is it portal hypertension or pulmonary hypertension? CLD, is it chronic liver disease or is it chronic lung disease? PD, is it Parkinson's disease or is it personality disorder? So we should avoid using abbreviation that has more than one meaning to avoid confusion. There are some acceptable abbreviation that only has one meaning. For example, ESRF, it can only mean end-stage renal failure, for example. Now, in per PD 301, there is also a section for documenting procedures that have been done and carried out for the patient during the admission. However, not all procedures must be documented in per PD 301. So, what procedures not to document? For procedures, it can be divided into two: operative procedures and non-operative procedures. For operative procedures, all operative procedures must be documented in the discharge form. The same goes for radiological procedures, for example, X-rays, ultrasound, CT scan, and MRI. But for radiological procedures, we must specify the anatomical location that the procedure is being done. For example, chest X-ray, ultrasound abdomen, CT thorax, and MRI brain, for example. There are some non-operative procedures that do not need to be documented. For example, nursing and routine procedures which do not require specialized staff and do not require specialized equipment. For example, routine dressing, vital sign monitoring, sponging, IO charting, and GTS charting. These procedures no need to document in the discharge form. Another example is setting up peripheral arterial and venous line, no need to document. All routine blood investigation, no need to document except blood CNS. Other example, oral medication, no need to document. Injection of medication, yes, need to document. Oral diet, no need to document, but for enteral nutrition or parenteral nutrition, we need to document. Some challenges and errors that can occur when documenting diagnosis in morbidity cases. Incomplete PD 301, either no main diagnosis or comorbidities, like earlier examples. No main diagnosis when the person document alleged MVA in the main diagnosis. Wrong placement, repeated diagnosis in multiple sections. Using vague and confusing abbreviation and acronyms. Illegible handwriting, unrecognized or unfamiliar symbols, writing multiple diagnoses in a row, and also writing procedure as diagnosis. I'm sure everyone knows that what the symbols mean, but we should not use this symbol in writing the diagnosis in the discharge form. So let's look at some examples. In this case, it is a bad documentation because the person document multiple diagnoses in a row. There are 7 diagnoses in section 1. We should only select one, the most severe diagnosis as the main diagnosis. In this next example, the person document same diagnosis in multiple sections, section 1, section 3, and section 5. No need to repeat the same diagnosis in multiple sections. This one, inappropriate main diagnosis. We don't know what exactly is the diagnosis. Transfer to HUSM as planned. This case was actually a child with acute leukemia and was referred to HUSM for a procedure. So the plan was to transfer to HUSM for that procedure. But for the main diagnosis, we should still document acute leukemia as the main diagnosis instead of writing plan for the diagnosis. In this example, the person documents suction and evacuation as a main diagnosis. It is wrong because we cannot document procedure as the main diagnosis. Procedure in section, I can't remember the next page.
Wrong placement, contohnya kalau external process tu dia tulis kat main diagnosis kan, intake of dekat station level. So you all coding macam mana? You all ambil kira kan atau?
Yes, we still code for that external cost. But in the discharge form, it is wrong placement. But we still give assign a code for that external cost. For example, the person document LHMVA with open fracture of right femur. So for the main diagnosis, we code the open fracture of right femur, and for the external cost, we code for LHMVA. Yes. Not redo, but we give a code accordingly, and before we enter into the CME system.
Equation ni you all can code juga lah.
Yes, we code the only if the person documents suction and evacuation in the procedure section.
Kalau macam ni, you all tak code lah.
We try to see if the person mentioned anything about, for example, silent miscarriage, for example.
So you will have to record again the procedure for this suction and evacuation. You will put it in the ICD procedure part.
Yes.
And then the diagnosis you will put it again based on your reference to the PhD.
Yes.
Dalam main dokumen kan, kita tak boleh nak writing. Nak replace tempat lain.
We should not like alter the discharge form actually.
Can alter.
But we try as much as possible to see if the person mentioned anything. For this case, for example, if the person mentioned silent miscarriage, so we will put that as a main diagnosis.
Nobody can alter that. Even the one who entered the facts also cannot alter.
We not alter per se. We cannot alter the discharge form, dispatch from ward. But before we enter the code into the system, we try to look for information and we give codes accordingly. Not to say that we do the discharge form again.
Ini juga akan cuba coding jugalah.
Yes.
Semaksimum yang boleh lah.
As much as we can get information on. In this next example, writing abbreviation that can cause confusion as the main diagnosis, MPD. So we don't know what is it exactly. Is it myeloproliferative disease or is it multiple personality disorder? So we should avoid using abbreviation. In this one, abbreviation and also procedure as the main diagnosis, it should not be documented as a main diagnosis. For the main diagnosis, we document in this case, if I can see correctly, right eye hyphema, so that one should be the main diagnosis. And this one should be documented in procedure section. This one, no clear diagnosis, reassurance, so we don't know what is it exactly. This example, possible cow, so we don't exactly know what it is. I think the person was copy and paste from the history and did not double check whether it's a complete copy and paste. I think what the person means is cow's milk protein allergy. So it is important to double check when copy and paste. And this one, another example of using copy and paste. So just numbers. This case, when we check the history, it was actually a case of referred case for back pain. And after investigation, after MRI done, it was actually a pyogenic spondylodiscitis of T12 to L4. So this one should be properly documented in the main diagnosis. This for procedure section. As mentioned earlier, some routines, procedure, and some nursing procedure should not be documented in the discharge form. So blood taking and IO charting no need to document. This one, patient is reviewed. So this one is actually what has been done for the patient in the ward. So the doctor reviewed the patient, but we no need to document that the patient is reviewed in the ward. And is in this example, only procedures that we should document in the procedure section, not to copy all the discharge plans in the procedure section. We have seen some example of bad documentation, so we will look at some example of good documentation. For this one is a medical case. For the main diagnosis, the person documented chronic obstructive pulmonary disease with acute exacerbation. And for other diagnosis, the person documented non-insulin dependent diabetes mellitus without complication. In this next example is a surgical case, ascending cholangitis with choledocholytitis. I know that I mentioned earlier that we should not document multiple diagnoses in a row, but there are some conditions which we can document together and can be assigned as a single code according to ICD-10. So, for example, choledocholytitis, if the patient also has cholangitis, like in this case, it can be documented together and will be coded as K80.3. If the person has choledocholytitis with cholecystitis, it can be documented together and will be coded as K80.4. And if the patient only has choledocholytitis alone without cholangitis or cholecystitis, it will be coded as K80.5. So it is important to be specific in the diagnosis.
Diagnosis utama sepatutnya dari choledocholytitis sepatutnya kan, and then dia punya complication is ascending cholangitis, right?
No.
Sepatutnya lah. Tapi because of the coding, I can come together all these diagnoses.
Oh yes. For other conditions that no specific code for them to be documented together, we should document separately. I just show this example that there are some conditions that we can document together. In this example, for obstetric case, the case of post-emergency LSCS for fetal bradycardia. For obstetric case, for the main diagnosis, when it is a case of LSCS, we have to specify the indication for the LSCS as well. For example, in this case, the indication is fetal bradycardia. And in other diagnoses, we should document delivered single live baby. If it is a single baby, if it's twin, then document delivered twin, both baby alive and good ALGA score, for example.
Yeah. So is 30 years old is para to deliver at semua ni adalah diagnosis. Kena masukkan semua kan? 30 years old, para to memang patutnya tidak.
For the age, no need to document, but for gestational period or para, we should document because sometimes there are codes for them. For example, pre-labor rupture of membrane, for example. So we need to see the gestational period. So if it is less than 37 weeks, there are different code for that. And if it is after 37 weeks, there are different code for that.
For this kind of case, should we, rather than put it the main diagnosis that lengthy, should we just put it as fetal bradycardia?
I think for completeness, we still need to mention para 4, post-emergency LSCS for fetal bradycardia.
Pre-text or memang ada dalam ICD coding?
For ICD coding, we will code the main diagnosis as fetal bradycardia, and the secondary diagnosis will be post-emergency LSCS.
Itu dah bawah diagnosis lain-lain right?
This is special for obstetric case.
Kita tak masuk bawah prosedur.
This is for obstetric case. For example, post-spontaneous vertex delivery, we have to mention that in the diagnosis. Only for obstetric case. Post-emergency LSCS, post-spontaneous vertex delivery. Yes.
Sebenarnya, kalau kita pakai yeah, the main diagnosis to patient admitted because of fetal distress. Pregnancy, fetal distress. And then the procedure, patient proceeded with seizure. Bukan patient had previous seizure.
No, in this case,
So the main diagnosis is fetal distress.
yes, fetal distress and also post-emergency LSCS.
Post-emergency is not the LSCS is not the main diagnosis.
Yes, it will not be coded as the main diagnosis. The main diagnosis will be fetal distress.
Fetal distress.
But for obstetric case, we document them as a single sentence.
Soalnya kalau kita masukkan LICS dekat prosedur kan macam susah lah kan sebab tu tak.
For the LSCS, we still document in the procedure section. Yes. Yes, post-emergency LSCS for fetal bradycardia in this case. Yes, this is only for obstetric case, not for other like for surgical case, for example.
It cannot be included the post LSCS because fetal distress, patient came with pregnancy with fetal distress. Yeah, after maybe come admitted with IV3 reassurance, then there is no more fetal distress. There is no more bradycardia. So there's no need for cesarean section. So the main diagnosis is fetal bradycardia, not the LSCN.
For this case, the patient was admitted for fetal distress and then proceeded with emergency LSCS. So we document as post-emergency LSCS for fetal bradycardia. Only for obstetric case because we have code for that. Like for example, fetal distress 068 and for post-emergency LSCS 082.
Untuk emergency fever tu, kita dokumen dekat prosedur, so yang tu kod lain pula.
There is a different code for that. For procedure with ICD 9CM. For example, LSCS, if I'm not mistaken, it will be 74.1. But for diagnosis, if post-emergency LSCS, the code will be 082.1. Okay, we move on to another example. This one is a orthopedic case. The main diagnosis, closed comminuted fracture lateral third right clavicle. This is a good documentation.
Sorry, ini nak tanya. Tadi kan, katalah kalau doktor dekat diagnosis tu dia tak tulis season. Tapi dekat prosedur dia tulis season. So adakah you akan coding juga for ICD-10 untuk diagnosis prosedur?
Yes.
Walaupun
But the main diagnosis will be the indication for seizure. In this case, fetal distress, it will be the main diagnosis. But in other diagnosis, secondary diagnosis will be post-emergency LSCS.
So lain coding dia?
Different coding, yes.
Different coding? Kadang-kadang kita tahu dia kan?
For example, patient post spontaneous vertex delivery with first degree tear. So it will be coded as the main diagnosis post spontaneous vertex delivery, O80, and secondary diagnosis will be first degree tear, O70.1, if I'm not mistaken. Only for obstetric case, we should not document like this in cases from other department. Special for obstetric. Okay, we have Dr. Faiz here.
Yang untuk kami diagnosis issue dan juga indication of seizure. Contohnya dia delivered SBD, so the main contohnya dia delivered via seizure, so the main indication for seizure. Cuma dalam evaluation dah tak lagi ialah the mode of delivery. Sebab yang mode of delivery ni ada code. Contohnya mode of delivery caesarean section. So the main indication dan diagnosis yang kedua ialah the mode of delivery. Itu tahapan yang evaluation. Ini kita masukkan juga mode of delivery. Indication for section, delivery dan juga outcome. Ini semua tiga benda ada. Indication, delivery dan juga ada outcome. Untuk indication dan juga delivery
in this case, the outcome is the delivered single live baby. That's the outcome of the delivery. Okay, I hope that's clear. In this orthopedic example, as I mentioned earlier, for the main diagnosis, it was a good documentation, correct documentation, because we have a type of injury, comminuted fracture, the site of injury, lateral third of right clavicle, and because it is a fracture, the person also specified it is a closed fracture. And for all other injury, the person correctly documented in other diagnosis. In this case, a closed fracture, right second and fourth anterior rib, superficial laceration wound of right clavicular area, right lung contusion, and right abdominal wall contusion. And for the external cause, the person documented as a alleged MBA, motorbike collided with car. So this is an example of a good documentation. So before I end my presentation, these are some take-home messages from today's CME. Please make sure that the main diagnosis and other diagnoses are documented properly. For comorbidities and underlying diseases are also documented properly. Main procedures and other procedures are documented in relevant section. But remember that not all procedures must be documented. And all procedures executed by all other allied health personnel must be recorded, not just procedure carried out by the doctor, for example. The discharge form per PD 301 must be signed and stamped by both discharging doctor and also from by the verifying doctor, whether it's MO or specialist. Both person need to sign and stamp the discharge form before dispatching to medical record department. So these are my references. It can be found from the internet if you want to refer. The first one, the one that we use, provided by TKM, Reference Manual for Clinical Diagnosis Documentation according to ICD-10. We, in medical record, use this reference for giving codes for some condition, some common condition. And the second one is actually Manual for Documenting Diagnosis in PPD 301. I think nowadays we provide this Manual for Documenting Diagnosis for new household, if I'm not mistaken. So thank you for your attention. Is there any question?
Can you go back to your take-home message? Yeah. Here, one of the things that you should include here, you highlighted in your presentation is do not use abbreviation.
Yeah.
You should clearly highlight that here. But again, you say, instead in a failure, SRD is acceptable. It also should not be acceptable. Abbreviation cannot be used.
Yes, I know that. I'm just saying that there are some abbreviation, some standardized and acceptable. We can still use it, but as if possible, if we are able to, please avoid any abbreviation at all. Totally, yes.
I think that should be the way. You should highlight this. If we allow some form of abbreviation, it becomes a habit.
Yeah, I know.
So you should highlight as part of your take-home message. Do not use whatever form of abbreviation.
Yes, that is correct. Thank you. Yes.
Okay, if let's say a patient admitted for let's say diabetic ketoacidosis, okay, and then the patient has fall in the ward, resulting in intracerebral bleeding. So this fall, do we need to write in the external causes, or we need to write in the complication? I mean, morbidity as a complication in the hospital. And what will be the main diagnosis? Is it ketoacidosis or intracerebral bleeding?
I think for this case, because the patient was admitted initially for diabetic ketoacidosis, so that will be the main diagnosis. But during the admission, the patient had a fall and had some injury. This one should be documented in other diagnosis and also include the external cause of injury.
Or as we put in the
external cause of
external
injury.
cause,
Yes.
even though it occurs in the hospital.
Yes, because the person sustained some injury.
Earlier you mentioned morbidity.
And
which one of you did you?
That one is we have section. Section 6, complication diagnosis.
Intracerebral hemorrhage and fall. It's like morbidity.
Katanya complication lah. So kalau kita letak dekat external causes, dia tu dah macam yang sebab dia admitted. Ini happen in the ward.
I think for the complication, we can write the injury that the patient sustained from the fall, but the external cause will still be the fall, alleged fall, because that will be coded as an external cause of injury. But the complication diagnosis, we can document as the injury that the patient sustained from the fall.
I think ICB itu documented as complication, bukan diagnosis lain.
We have codes for each condition. For alleged fall, for example, and for the injury that the patient sustained from the fall, we have codes for that. For example, laceration wound over scalp area, for example, we have codes for that. And codes for alleged fall, there are different codes for that.
Alleged fall, and then patient tak ada luka lah katakan, tapi ICB saja. So tadi you kata as the alleged fall tu masuk dalam external causes. Kan ICB tu masuk dalam complication ataupun diagnosis lain.
So that can be recommended as a complication diagnosis because the patient sustained the injury during the admission.
Patient sustained the injury after admission.
Yes.
After admission, while in the ward, dia pening-pening jatuh.
So we document the injury that the patient sustained from the fall in a complication diagnosis, and the mode of injury that the patient had a fall, so we document in external cause.
Ya, tak boleh dia check tu. Dia beritahu balik ni. Memang confirm. Sebab saya sebelum ni saya ada dengar lain pula. Dia masuk dalam complication.
Okay, can I please ask Dr. Faiz to verify this?
Because the fall happened during the period of care, so the patient had fall during the admission, so we put the diagnosis of fall under the diagnosis of yes. Yes. This complication.
Yes, so both conditions will be coded differently.
Both conditions can document under the section of the yes. It shouldn't be the problem. There's still there will be two groups for that. Because every injury there must be external group. Tetapi kalau kes contohnya masuk ke IPP, dia macam dan dia dapat fall. Kalau dia duduk dalam waktu lama misalnya, sebab kalau fall dia, kita boleh ambil diagnosis itu sebagai yang fall. Kalau contohnya masuk sebagai IPP, tetapi ada berlaku fall dalam ward, dan fall itu menyebabkan dia duduk dalam ward lama. Banyak resource digunakan CT beri, positif pain, dia terpaksa masuk operation, treat the break, so kita boleh ambil dan diagnosis for me. Sebabnya untuk diagnosis ada dua kriteria yang berbeza. Pertama ialah reason why they be admitted. Kalau ada multiple condition, kita kena tengok balik kriteria. Kriteria yang kedua ialah yang gunakan research dan yang menyebabkan patient lama dalam. Contohnya masuk sebab stroke, tapi dia ada komplikasi state acquired pneumonia, dan state acquired pneumonia menyebabkan dia dalam ward menggunakan multi high-end antibiotics, so kita akan choose the state acquired pneumonia as the analysis.
Dengan fall.
So contoh tadi DA dengan fall ada multiple diagnosis. Sebenarnya kita tengok balik kita lihat if there is more than one such condition, the one most responsible for greatest use of research reported should be factor. Kalau banyak resource guna, so kita boleh select will become the maintenance. It go back to the clinical judgment of the managing.
Okay, thank you, Dr. Faiz. It is like Dr. Faiz explained. For this case, for example, the patient initially admitted for diabetic ketoacidosis, had a fall and sustained some injury. if there is that injury caused the patient to be warded for example, 2 months and underwent multiple operation and multiple CT scan, for example. And before discharging the patient, the managing team should select the one that most severe as the main diagnosis. But if the patient admitted for diabetic ketoacidosis had a stage 4 and only small ICB and does not need any surgical intervention, then the main diagnosis should still be diabetic ketoacidosis. Okay, thank you, Dr. Faiz. Any other question? If there is no more question, I would like to thank everyone for your attention for today's CME. And I would like to apologize if any shortcomings from myself. And thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Zulkifli, for the very informative presentation. So I would like to invite Dr. Putri Nurbaya to deliver the certificate of appreciation to our respected today's CME presenter today. Please welcome. So with that, we have come to the end of the today's CME session. The upcoming CME will be presented by the orthopedic department with the topic of malignant peripheral nerve sheath tumor by Mr. Ahmad Munir and Ms. Dr. Wan Muhammad Amir. Thank you, everyone. Assalamualaikum warahmatullahi wabarakatuh.